Mr. Crow is an 82-year-old man who has a medical history of low blood pressure, stroke, COPD, pulmonary fibrosis, muscle weaknesses, clinical obese, additional information, short-term memory, falls, reduced mobility, and a history of being a smoker. Mr. Crow was admitted in a nursing home from the community hospital. He felt uneasy and he wanted to go home. He was withdrawn in the nursing home. He had a wife and 3 children who had asthma. The 3 children were all grown up. During his stay in the care home, he was upset and tearful at times. Reasons for admission in the hospital in the care home. He suffered a stroke and he was admitted in hospital. With a long stay in hospital, Mr. Crow was transferred to a community hospital. He was also offered an ICT intermediate care bed in the care home to support rehabilitation. This is offered to people who are considered unsafe to return to their own homes but who have the capacity of living in their own homes if provided with suitable support and rehabilitation services. The service focuses on those who are at high risk of prolonged stay in hospital. According to England NHS UK, inpatient admissions is a major cost driver in COPD management, accounting for 54% of the direct costs associated with its management in the UK. ANON 2017 suggests that COPD causes 115,000 emergency admissions, 24,000 deaths per year, 16,000 deaths within the 19 days of admission. The cost of hospitals is significantly influenced by the length of hospital stay. According to Pring and Swinch 2014, an American Journal, step-down beds may be used to provide a higher level of care for patients who are not rehabilitating on the ward. Mr. Crow and his wife are both pensioners receiving state pensions, which means that they are both on low income and they live in a council house. According to Age UK, there are support systems for over 60s and they get free prescription, eye test, and depending on entitlement, they get things like council tax, housing cost, heating, agent one-off expenses. Using the diagram and Whitehead 2003 to look at Mr. Crow's influence on health in order to map up the relationship between individual and political factors and societal and global factors. Due to him working in a factory of that handled asbestos, greater understanding of the causes of industrial lung disease, as well as enforcement of legislation by the government, have reduced the risk of industrial dust disease. In the past, industrial UK had lack of knowledge of the link between COPD and asbestos. Industrial lung disease has a link of occupational rather than an inherited one. According to the Telegraph of Obzon 2017, Lady Thatcher saw a decline in manufacture that causes unemployment and two recessions while she was in power. There was a period when Mr. Saw lost his job and remained unemployed. According to WHO 2017, despite asbestos plant closures, cases of asbestos-related occupations diseases among former asbestos workers are still recorded in Poland. The program also allowed the government to generate a reliable estimate of the number of asbestos-related occupations. Menothelum Center 2017 says that the UK residents who die from the disease are older than 65, like Mr. Crow. This was thought to be the potential dangers of asbestos. In the 1970s, it became apparent that asbestos-related disease was on the rise in England. There were legislation put in place to act, control, and possibly ban the use of toxic material. In Great Britain, employers also have great obligations to ensure that the workers receive adequate training information, instruction, and about hazards in the workplace and how these are controlled. In specific terms, relating to COPD, evidence supports a relation between the increase of awareness and respiratory problems within the workplace area. If any doubt, you can claim for industrial lung disease and training, inadequate training. National legislation to prevent exposure to COPD varies geographically in Great Britain. For example, employers and their workers have responsibilities under the Control of Substance Hash of Health (COSH) regulations 2002 to prevent potential harms and exposures to agents in the workplace. However, there's little published evidence to assist employers and workers when considering how they can reduce the risk of COPD related to work, or how best to identify and retain those with COPD in the work environment. Clinical strategy for COPD and asthma in England and Wales, produced by the Department of Health, emphasize the importance of workplace exposures when considering COPD. This was the perspective of not only reducing exposures to potential harm to VGDE, but also modifying the risk of work, including smoking, and how best to retain those with COPD in work. According to WHO 2017, smoking is the largest health threat in the world, killing 6 million people per year. The UK government on the 1st of July 2007 passed a law to banning smoking in public areas, with penalties on those who commit the crime. This also made individuals more aware of secondhand smoking, as WHO 2017 argues that there is no safe exposure to secondhand smoking. For example, the fact that the patient was a heavy smoker and his children are asthmatic. Robert Wanger and Carr suggest that counseling parents to adopt smoking bans in their homes and car has heightened awareness, and there was no information about secondhand smoking when Mr. Crow was smoking. It has impacted Mr. Crow and his family. When he lost his job, it meant long-term unemployment. His well-being was at risk, and as he made poor life choices, his unemployment status and heavy smoking affected him biologically. Evidence suggests his job and smoking played a major role in his COPD pulmonary fibrosis 2017. WHO. In process, psychologically, Mr. Crow is feeling withdrawn and fearful and very upset at times about his improvement. He states that he's missing being with his wife and he's lonely. This could be an indication of possible depression, which can be caused by his feelings and maybe feeling isolated. According to NICE guidelines, with long-term physical health problems can develop depression. This has potential to decrease their quality of life and life expectancy. Encouraging activities and monitor the patient's response to the activities and encourage interaction goes to set. Assessing the patient's understanding of the disease process, identifying learning needs, and so that teaching can be individualized. Mr. Crowley smokes, so the aim is to urge him to smoke if necessary, manage Mr. Crow's symptoms, and refer Mr. Crow to a specialist to ensure high quality of care. Conclusion: to provide a personal-centered care to Mr. Crowley, regular monitoring and assessing Mr. Crowley. The process has also contributed to continuous professional development, and it is anticipated that knowledge and skills acquired during this project will enhance future patient-centered care practice.